Good afternoon to everybody, and we welcome you for this instruction course. And I would like to thank the AIOS for giving us this opportunity. Now, in this instruction course, which is on the roller coaster of trabeculectomy and how do we have a successful outcome of a glaucoma filtering surgery. So we will be talking about the tricks and the tips that how do we achieve the successful outcome after trabeculectomy. And I think all of you would agree that TRAB is one of the surgeries which most of the anterior segment surgeons, whether they are qualified glaucoma people or they are not qualified glaucoma surgeons, they would like to do a trabeculectomy because everybody feels that this is a very, very simple surgery. But once you have done a number of TRABs, you realize that though it appears very simple, but there are a lot of complications which come along with trabeculectomy and which you have to learn to manage. So with this idea in mind, we have designed this instruction course which will be talking about that whenever you decide to do a filtering surgery in your glaucoma patient, how do you choose the right surgery, and what precautions do you take intraoperatively and in the post-operative period to increase the successful outcome. And who could be a better person to give the introduction to this instruction course than Professor J.C. Das. I think he needs no introduction. He's been one of the most senior glaucoma person countrywide, and he has taught many of us. He has had so many years, almost I think nearly 50 years of experience in teaching profession, and so many students have come out of his guidance. He has been a past president of Delhi Ophthalmic Society and the Glaucoma Society and have innumerable publications and awards to his honor. And he is one of the first ones who bought actually the glaucoma drainage device also popularized in our country. So I think I would request Professor Das to give us introduction for this instruction course. Sir.
Thank you, Dr. Parul, for the kind words. And welcome to all of you in the practically lunch session. The thing is, we choose glaucoma surgery when drugs fail. In most of the cases, the primary cases are very few and far between, and that depends on the personal choice of many people. But as a routine, most of us do trabeculectomy as the first choice, and we feel that the end of the story. No, it is not the end of the story. Actually, this is the beginning of the whole story. Once you resort to surgery like trabeculectomy, you are heading for complications or failure rate very soon. If you consider the success rate, the success rate reduces to 60 to 70% in 2 years' time, and it reduces to 40% in 5 years' time, and that continues. That means almost 60% of the patients are likely to fail in 10 years' time maximum. That means you have to repeat the TRAB again after 10 years. If the patient's age is 20 years, every 10 years you repeat the surgery then. So this becomes a difficult proposition. Apart from the success rate, when it didn't work, then we thought of using mitomycin C. Success rate increased tremendously, but at the same time the complication rate also increased very, very high level. The complications like bleb thinning occurs in roughly 60% of cases, and one study shows it is 67%. Bleb leak in 15% of cases in 10 years' time. Infection, patients lands with, one of the reports shows in 85% of cases there is risk of infection, and that infection has really happened. So if that is the complication rate of trabeculectomy, where do we stand? Not only the complication of bleb-related complications, what happens to the cataract? In a normal young patient, 24% of the young patients develop cataract very soon. 47% of uncomplicated surgery ultimately land with complication or land with cataract formation. If it is diabetic patient, the chances are 75%, and if it is a complicated glaucoma surgery, then the chances are almost 90%. That means if you take minimum of this, roughly 40% of the patient is likely to develop cataract sooner or later. What happens to the fields? In spite of a successful surgery with the trabeculectomy, the field progresses 25% of cases in first year, and in 10 years' time, the field progression is found in 58% of cases. That means we have got this, the reduced rate of success, we have got the complications, and of the cataract formation, visual field progresses. Where do we stand then? So naturally, we are concerned that how to minimize these complications and increase the success rate. And to increase the success rate and the complications, you must choose a right surgery for the right patient. And certain surgery is good for a certain situation. Trabeculectomy is not a common surgery for all types of patients. So we have to choose, pick and choose according to the patient's need, a surgery which is suitable to us. And there are few basic things which are very, very important for trabeculectomy. The prevention is the best form of treatment. That is one thing very, very clear, one must understand it. Second, trabeculectomy is not just a science, it is also an art of treating a patient. That means each step, including preoperative preparation, maybe 1 week prior to this, and each and every step during surgery and immediate post-op period are important, and important to equal extent. So if you want to increase the success rate, increase decrease the complication rate, one must be very, very meticulous and to follow all the steps even preoperatively, during surgery, and immediate post-operative and later on. Nowadays, the more options are available. We have got more flexibility, and certain surgeries are not suitable for certain cases, that one must remember. For example, I'll tell you which are the surgeries which is soon to do or we should do. Say in general, if the intraocular pressure, the target IOP is less, then you go for a trabeculectomy with all the precautions, trabeculectomy with mitomycin C, or you can do a tube with all the precautions, or you can do a suprachoroidal type of drainage devices. If you feel that the intraocular pressure lowering is a must and it should be around 10, then you go for a surgery which is associated with a little more complication, but the target pressure is likely to be achieved further. If the target intraocular pressure is supposed to be little high, that means it's a mild to moderate case of glaucoma, then we have got a lot of options nowadays. And like all the MIGS surgeries, microinvasive glaucoma surgeries, including the GAT or gonioscopic assisted trabeculotomy and deep sclerotomy and trabectome, and all those MIGS surgeries are available when you feel that the intraocular pressure level should not be that low. We don't need it in the lower teens, should be maintained at 17, 16, 17, because the glaucoma is not very advanced, it is early stage. And more than what surgery you choose, it is more important to choose which surgery you should not do. That is more important. Like in medication, that which medication you should not use for certain situations, general conditions or local conditions. Similarly, you don't use certain surgeries for certain glaucoma type of glaucoma, that you must remember. I'll give you some examples. Say for neovascular glaucoma, for eye syndrome, post-VR surgeries, post-PK surgeries, where you expect that the trabeculectomy is likely to fail, don't do it, as simple as this. So go for another surgery like, or even in cases of childhood glaucomas, you prefer a tube with all the precautions you have to take. Second is, suppose we have got the aphakia with vitreous in the antechamber, don't go for trabeculectomy, is likely to be fail. So it is always better to do a vitrectomy followed by tube surgery, that gives comparatively better results. In cases of the collagen disorders, collagen vascular diseases, where you expect the scleral melting is common, don't use mitomycin C. So these are the things we must keep in mind. Other ocular surface disorders, where the like pemphigus or pemphigoid, where the conjunctiva is scarred, don't for the trabeculectomy at all, then go for the tube. For example, another surgery which is not very commonly done, we have to learn it, is the endocyclophotocoagulations, which can be done along with the cataract surgeries, and for a specific type of glaucomas like a childhood glaucomas. In case of neovascular glaucoma, choose a surgery like endocyclophotocoagulation. That is another better choice. And you don't do a gene type of implant in angle closed glaucomas, and in if there is a lot of scarring, or in neovascular glaucoma, you don't do it. So avoid any such surgeries in cases of, if you are planning for gen implantation, don't do it in those cases. And GAT is the gonioscopic assisted transluminal the trabeculotomy is not done in cases of bleeding diathesis, or those patients who are already on the anticoagulants. So they are likely to land with repeated hemorrhages. So don't plan for GAD surgery in such situations. And for patients which are very obese, you may have to change the your decision right on the table. If the patient is very obese, has got very thick neck and a short neck, likely to cause a positive pressure during surgery, likely to land with a suprachoroidal hemorrhage, better you don't go for conventional surgery with trabeculectomy. For example, if you are doing a surgery for a very high myope in a young patient, don't use mitomycin C, or use mitomycin C in the lowest concentration with the lowest possible time. So these are the things we must keep in mind, what not to do during the surgery. So many options are coming up. If you feel that these options are practical and you can do it, there is a lot of learning curve, though it takes very less time and looks very simple, it takes little time to learn. So it is better that we set up our mind to change the surgical pattern, keeping in mind the complication rate of the conventional trabeculectomy. With these few words, so I'll hand over to you to call the next speaker.
Thank you, Professor Das. And I think this was a nice introduction explaining that how one can land up in complication if you make a wrong choice. And this is precisely